Yeah, good evening all and welcome. This is Sundeep Akula from NATCO team. You are listening to another special episode of Respire, lung cancer awareness, one voice at a time. It's a joint initiative by NATCO as well as Voice of Healthcare. Respire. Respire is nothing but raising awareness to fight against the lung cancer. As you all know, lung cancer remains one of the leading cause of cancer-related deaths. And also in India, there is a lot of misconception, myths, and gaps to understand it. So it falls under the shadows of expertise as well as focus. So today we have with us a renowned medical oncologist, Dr. Avinash Kumar Pandey from Paras and Amri Hospital, Patna. Welcome, sir. It is always pleasure to have you on this Respire platform. Over to you, sir.
So hi, good evening to you all. Yeah.
So first, understanding the burden of lung cancer, sir. What is the increasing trends if you see lung cancer in India?
Yeah, so I have been working in oncology since last 2 decades almost. And to begin with, in my career, we initially used to have a lot of middle to elderly age men who had presented with a cough and chest mass in the center. And most of them had a history of heavy smoking for like 20-25 years. So the last 1 or 2 decades, gradually the trend has been shifting, and we are getting a lot of middle aged men as well as women, people who smoke, as well as people, at least 40% of them who are non-smokers, who do have such kind of a lung cancer. And 2 decades back, we used to see central tumors, which we call as squamous cell carcinomas. Now we are seeing more of peripheral lung tumors in the side of the lungs. So they are tiny, they are quite distal to begin with, and they are more common in women, and there are more adenocarcinomas. So we can see a change or shift in the pattern of a presentation of lung cancer over the last 2 decades. So we are moving from a only smoking restricted lung cancer to a mixed population of smoking and non-smoking lung cancer, including now middle-aged men as well as women as well as elderly age group. So this is a shift which has happened in last 2 decades.
Okay, so there is an involvement of age-related group. The risk is coming down at age standard age.
Yeah, so a lot of younger people are getting exposed and getting diagnosed then, which was not that common 2 decades back.
Okay, so when you talk about this smoking and non-smoking, even non-smoking people are also getting affected.
Yeah, so as I told you, the etiology is slightly different between smoking and non-smoking. So initially, like 15-20 years back, most of the packets of cigarette used to be poorly filtered or unfiltered. So those particles used to get collected in the central part of the lung. So they used to call more of a central tumor or squamous cell carcinomas. Now the cigarette which is coming is more of a filtered and a refined form. So people who do smoke take it more deeper puff and keep it inside their lungs for a longer period of time. That causes these particles to go inside the lung at a deeper level, at the peripheral level. So they are now causing these cancers at the peripheral level. Apart from that, because of urbanization, because of pollution, because of mining, because of construction, lot of automobile use, and a lot of, in Delhi you would have heard of smoke in the winters, which also contains a part of ozone, then radon gas, all these things, secondhand smoking, automobile exhaust, industries, river pollution, all these things, arsenic pollution in soil and water, all these non-smoking related causes are also kind of a harming one on top of other, especially in urban cities and metros. So that's why the shift has happened from elderly to middle age, from men to also women, from central to peripheral tumors, and not only smokers but also non-smokers are getting these tumors now more commonly.
Okay, so beyond tobacco usage, you have explained so many risk factors. So,
Yes,
sir, the
yes.
occupational exposure also contributes to lung cancer.
Yeah.
Right,
So occupational exposures there, especially in construction, workers who get exposed to asbestos fibers, they have more prediction of causing peripheral lung cancers and what we call as the mesothelioma. For example, in Delhi, there's a lot of air pollution going on. So this most of the exhaust from the vehicles which we see, they have something called as a polycyclic aromatic hydrocarbons. They are very tiny particles of nitrogen oxide and sulfide which goes inside your lung, and we call as a particulate matter. So this particulate matter less than 2.5, they are so tiny they go deeper inside the lung. They cause irritation, inflammation, DNA changes, and these causes after 10 to 15 years of such exposure converts into a peripheral kind of a lung cancer, which we are seeing more now in middle-aged men as well as women, especially in urban cities, urban centers.
So then it plays a crucial role to detect early, right, sir?
For example, if we somehow detect a lung cancer in a stage one, almost 95% cure rates are there, and so it does decrease this to less than 10% in stage four. So yeah, if we somehow are able to diagnose these tumors at a very small level in the peripheral 2 centimeters, then probably they could be cured by a simple surgery.
Okay. And what are the current recommended guidelines for screening of this lung cancers?
So
Generally.
generally, we do not recommend lung screening for each and all. So there are certain high risk groups where doing a certain kind of a screening helps us in picking up more refined early lung cancers. So these people would be aged between 50 to 80 years, and these people should have a history of at least 15 to 20 years of smoking. So they should have been like one cigarette packet consumption for like 15 to 20 years. If we call it that a smoke years, so smoke years back. So if these are risk factors are present, if someone in the family history has a kind of a lung cancer, these cohort of patients, if we subject them to low dose CT scan, the low dose CT scan is actually very different from a diagnostic CT scan. In diagnostic CT scan, we use contrast, and that radiation is 10 times more than a low dose CT scan. This low dose CT scan done once a year, it just requires 30 seconds of your time. It requires a breath hold method. And most of the majority of CT centers across India are equipped to be kind of a diagnostic or a screening low dose CT scan. They take refined cuts of the lung on a full inspiration test for 30 seconds, and the computer algorithm turns this into 5 to 1 mm, 2.5 mm small cuts. And here, uh, in certain cases, if the screen becomes positive, we can detect as low as zero point 0.5 to 1 centimeter tiny tumor sitting in the periphery of the lobe. And then, after confirmation with a biopsy, we can take that part of the lung out, which also called as a wedge resection, and that patient hopefully can be completely cured with it.
So when you talk about this low dose CTs diagnostic methods, they are also
Mhm.
affordable and available in tier 2, tier 3 cities, sir, because a lot of
Yes,
people come
the
from
most of the yeah, most of the modern multi-slice CT scan which is available since last 5 years or 7 years, which is available in metros and also to some extent in two tier three cities, are able to do this test with reasonably accuracy. So someone who has this kind of a risk factor can be subjected to low dose CT scan once a year, just to make sure if they have some kind of a suspicious nodule, so that can be taken care of early.
Okay. So coming to the signs and symptoms of you were explaining about cough and other related things, should we really ignore, because some people may ignore in the initial times? So
Yeah.
what would be your take on this, sir? Should we ignore the symptoms or
No, so unfortunately, majority of the lung cancer, by the time they produce symptoms, are already in the third and fourth stage. So if the lung cancer happens to be in the center part of the lung, that will compress an airway cavity. So patient can have cough, breathlessness. It can have expectoration and a blood in the cough. These are the common symptoms. This can continue for a few weeks, maybe a month or so. This can be accompanied by a weight loss and some fever. So if you have someone, especially who is a known chronic smoker and have these symptoms of cough, expectoration with some blood in sputum for 3 4 weeks, and then he's losing weight and has fever, then he could be having either lung cancer or tuberculosis. So he needs to be examined either by a chest physician or oncologist to make sure which of them this person has. So this is some kind of thing. Apart from that, in many advanced cases of lung cancer, we do see patients having chest pain, patient having pain in the spine and the back, patient having hip pain, and patient having breathlessness because of lung tumor has increased or there's a fluid in the lung. Apart from that, lung cancer is known to spread to almost literally every other organ of the body. In some cases, it can go even in the brain and can produce headache as well as seizures and vomiting. It can go in your eye to cause sudden loss of vision. It can go in the liver to cause jaundice and right side abdominal pain. So all these symptoms do happen, but majority of them, by the time they come and present, are already in the stage 3 to begin or stage 4 to have been diagnosed. That's why this role of screening has come up, which can potentially save more lives.
oh, you talked about the signs and symptoms risk factors. And anyway, sir, beyond your experience of decade of experience, when you talk about this treatment, how does the treatment landscape is evolving in lung cancer, sir, from last decade? If you consider from the last decade.
Yeah, so actually, a decade or two back, we just had only chemotherapy drugs, and we can count them on the fingers. There were like five or seven chemotherapy drugs which these patients were exposed, and almost hardly anyone in a stage 4 disease would survive more than 8 or 9 months. That was 15, 20 years back. Then, because of a recent improvement in molecular diagnostics, we are subjecting almost all patients of lung cancer at the time of diagnosis using a biopsy, especially for adenocarcinomas and non-smokers. We subject them, the biopsy sample, to a subject of molecular genetic tests. They include special genes, sometimes like 5, 7, sometimes even 15 genes. If the patient has a biopsy sample showing any of those 7 or 8 common mutations, for which we have a special drug we call as a targeted therapy. So if they have that mutation, and if we subject them to drug, which 90% of the cases, if they have the mutation, they do respond to this drug, then these patients can have a very early, very prompt, and very deeper response. Within 2 weeks, the tumor decreases in size, symptoms decreases. By 3 to 6 months of this tablet, the tumor almost decreases by two-thirds, sometimes even 90%, and rare cases it goes completely off. And on these drugs, in these subset of patients, they can survive for 3 years, 4 years on this drug without getting any symptoms. If at all later they progress, then we use subsequent line of treatment, which may include chemotherapy or immunotherapy. Apart from that, since the last 2 3 years, immunotherapy has come up. So the patients who cannot have a benefit of these mutations and these drugs, we subject them to two other tests, which is called as a PDL1. Basically, it puts some colors on the biopsy and sees whether this receptor is present in a decent fashion on the tumor cells or not. If these receptors are showing a good positivity, then these patients can have benefit of immunotherapy. So immunotherapy is the kind of a biological drug which is given through the vein. And in these patients who have a good CPS score or tumor staining or PDL1, which we call in technical terms, these patients do respond very beautifully to immunotherapy. So we have currently like 5 or 7 patients who were terminally ill. They had stage 4 cancers, and they were later diagnosed to have a good CPS or PDL1. And they are now third year, fourth year of immunotherapy. They are doing very well. The tumor is not there. They are almost as good as completely cured. So in short, I would like to say that despite of being in stage 4 lung cancer, there will be 30 to 40% of these patients who would have a long-term benefit of either these oral tyrosine kinase inhibitors, oral treatment, or can have a benefit of this immunotherapy IV drugs. And these patients can survive for years and years without having much of disease, or sometimes even completely without disease. So that's a lot of things that happened in the last 2 years. So lung cancer, which 2 decades back, stage 4 was incurable. I'm not saying now we have made them curable, but we are making them survive for like 3, 4, 5, 7 years, which they didn't used to do it for more than a year, 2 decades back. So we have crossed a huge milestone in the treatment of lung cancer, and it's further evolving day by day.
Yeah, sir. So you talked about chemotherapy, targeted therapy, immunotherapy also. And
Yeah.
how far you consider, sir, your patients are getting good benefit with immunotherapy? How many? You
See,
said that 10 years.
so since last few
You
years,
said,
because of Indian pharmaceutical companies, which includes NATCO as well, they have been able to help us in getting the generic drugs at a very low price. So these drugs, which were very expensive 5 years, 7 years back, are now it comes within a few thousand of rupees for a month. And these patients are now taking it, even from low socioeconomic status who can afford this low amount of budget. They can take this drug and they can survive on this drug for years and years. Immunotherapy has till date has been very effective in certain subset of patients, but it is now available at a bit higher price, and it's only been marketed in India by few international companies. So the price is a bit on the high side. So not everyone is able to afford at this point of time, but people who do afford, they have very good response, and they keep on taking it for months and years. But I hope many Indian companies are in the frame, which include NATCO as well. They are building on Indian variant and generic of biosimilars of these immunotherapy. And maybe in the next 6 months or 1 year down the line, we'll get to use this immunotherapy Indian developed, Indian marketed, and Indian promoted drugs, which is will be very similar to the international one, and probably at a one third or even lesser cost. Then these things can be made available to a huge population of patients, and we can expect these patients to live for a very long period of time without much of troubles.
Okay, in coming days, it would be immunotherapy is also making accessible and affordable to the patients. Thank you.
Correct,
And
correct, correct.
when you see the impact of quality of life, sir, because psychological impact will be there on the patients about their quality of life and their doings, habits,
Yeah.
and all those things. It really affects, sir.
Yeah, yeah. So I can give you an
Yes.
example. Recently, there have been a 34-year-old male patient, non-smoker, and unfortunately, he got diagnosed with a stage 4 lung cancer just a year back. So he was very apprehensive about chemotherapy. Would he survive? Would he not survive? So we ran a genetic test, and his test has shown a marker called as a ALK mutation positive. And he's receiving a drug, and on that drug, within the first 3 months, the tumor is completely gone. There's no tumor, and in these 3 months, he didn't have much of side effects. He didn't lose hair. He didn't lose his appetite. He was able to do his all normal activities. His lung pain, chest cough has resolved within 1 week. So he just came 2 days back to me at about 1.5 years of taking that tablet. No symptoms, nothing. He's doing perfectly fine. In case he walks in any shopping mall or someone, no one can identify he is actually having a kind of a cancer inside him. So yes, in select subset of patients, the diagnosis, treatment, has become so easy that they hardly experience any subjectable or mentionable side effects. They do almost as good as a normal, healthy human being, and hopefully he will survive much longer. He'll do much better because of these drugs which have come. So yeah, a lot of change. 2 decades back, these patients, almost everyone used to get chemotherapy. They used to have hair loss. They used to have losses in weight. They used to have recurrent infections, a loss of taste, and then they used to have vomiting, diarrhea, complications of chemotherapy. Not everyone used to complete all the cycles of chemotherapy. So from there to now, almost being symptomless with just one tablet a day, near normal with no complication, no side effects. So we have come a long way in treatment of lung cancer in last 1 or 2 decades.
Okay. And so before treating a patient, what kind of psychological impact he will go through, sir? Before the because
Yeah.
cancer
So
itself is a
yeah, speaking about lung cancer as compared to other things, because majority of the patients which comes in my practice already have stage 3 and stage 4 to begin with, so they are very apprehensive and anxious about how they will do, and generally we subject them to molecular testing or IST, which takes about a 1 week or 2 week for the reports to come. So unless and until patient is very symptomatic, we ask these patients to wait for a week or two, let the entire report come to us. Because more often than not, especially for the younger patients, we do get such mutations, especially in females, and they can be having a near normal life with just one tablet a day. So, and obviously, there will be one third of patients who would not have these mutations, and then we would have to subject them to normal chemotherapy or immunotherapy. So, we have to make sure they understand that sometimes it is important to wait for the all reports to come in a 1 week or so. So, half of them will be having a tablet which doesn't cost much, which doesn't have much of side effects. So, these patients are going to enjoy a pretty near normal life with less disease. And the other half, yes, we don't have a choice. We still have to give chemotherapy and sometimes immunotherapy to them. And then with every cycle, every 3 weeks, we see them, we counsel them, we explain about the side effects, we treat side effects which is happening to them. And after 3 or 4 months, they do show a good response. And then we down escalate the treatment and then continue to the treatment in some of a maintenance IV or oral treatment for a few months and years. So these are two different spectrum of patients we have to cater in stage 4 lung cancer. So this has quite changed the last 5 years, which was not kind of a 5, 10 years back, which where we used to give similar treatment to all patients of lung cancer. Now it has changed in this fashion.
okay, sir. Even though, sir, so many options are available, treatment options, and the way procedures are available for treating lung cancer, but why there is a still lot of stigma around this lung cancer, sir? Why is it because
So
of lack of
major-
awareness, or what is that?
yeah, so we see, especially I practice in an urban setting. So most of the patients who come to me have a semi-urban or rural background. They are like middle-aged to elderly people. When they diagnosed with this cancer, most of them stage 3 and stage 4. First, it's very difficult for them to understand that they really have a cancer inside their body. And once they accept, then it becomes key. They are not, they are a bit apprehensive. Is it curable or not? Is it communicable? Is it okay to be safe with the patient in the same room? Is it okay to share the same bed? Is it okay if the patient touches me? It is okay if the patient has food with me, uses the same washroom, drinks from the same glass. A lot of misconceptions are there in the average community about cancer, especially lung cancer, because these patients usually have a lot of cough, they have hoarseness of voice, they have breathlessness. Some relatives are because especially after COVID, some relatives think even lungs cancer can be communicable by a cough and all. So we have to make sure that these misconceptions are taken care of by the patient relative. Because ultimately, it is the caregiver at home who need to adapt to his circumstances and situations and surroundings, and the caregiver has to be ensured that this is non-communicable patient. You can treat him as good as any normal individual in your house. He shouldn't be having any bias in your treatment, and the treatment which you are giving might have some side effects. He will respond in majority of cases. You have to be patient. You have to take care of his diet, nutrition, his function. Sometimes assistance to the washroom. Sometimes requires feeding, taking care of, bathing, clothing. So these all things we have to make sure in our day-to-day communication with patient as well as caregivers. Some of them are apprehensive that the patient should not know that he has a cancer of stage 4. So sometimes we do take into consideration, but we often inform their close relative, including the son, daughters, or the guardians, that okay, this is the scene. We are trying our best. Hopefully, things will improve, but there are some chances he might not do well. So all these things do come in a discussion with the patient and their relatives. But we have to make ensure the caregiver is an important team member of our whole panel, because he has to take care of the patient at home in majority of time. We'll be seeing the patient like once or twice in a month only in general.
Okay. Sir, a lot of insurance policies, health insurance, adapted by state or central are there. But even you find any key point this should be there in policymakers. What according to
Yeah.
you a policymaker should
Yeah.
policymaker
So
should do change in Indian
yeah, so because especially in cancer, especially in lung cancer, the situation is changing every few months. They're getting new mutations, new drugs, immunotherapy, and unfortunately, the policymaker policy is not that frequent and robust in adapting to the current treatment guidelines because of financial constraints and because of logistic issues. So, when the initial scheme of Ayushman Bharat was introduced, we had just had a few options for treating these patients. Majority of them having only 3 or 4 different chemotherapies and nothing else. So now we have slightly more versions of chemotherapy mentioned in the government schemes or Ayushman Bharat schemes. Apart from that, they still have not been fully adapt to the oral tyrosine kinase inhibitors or tablets, which we do give to certain one third of lung cancer patients. And almost most of the insurance policy, especially the government healthcare insurance policy, it still doesn't have immunotherapy offerable or preferable in their brochure, in their kind of a treatment guidelines yet, which majority of the Western countries have already adopted that. Maybe it will take 6 months, 1 year, 2 years down the line, because cost is also a constraint. But once the generic things comes inside, then hope these policymakers stick together at least once a year. They reform their policies, make it more wider so that more patients can enjoy the benefit of these new drugs and novel treatment, including tyrosine kinase inhibitors and immunotherapy, which is not currently approved in majority of the insurance things which is currently going on. Though do some private insurance companies do accept and allow this immunotherapy in certain cohort of patients, but it's not a uniform practice till date.
okay. Okay. Sir, anyways, you have explained clearly each and everything, and also the vital aspects, treatment options, everything. But as you said, the decade it's improving, the future landscape of treating lung cancer is improving. But what does
Yeah.
gives you hope while treating a late stage cancer patient, sir? Other
See,
than this, what does give you
yeah.
hope to treat this?
So I have been
as per your
practicing in
clinical
my
experience and clinical.
yeah. So I have been practicing in my center for the last 7 8 years almost. So when the patient whom I saw in 2018 and 19, if things would have not changed over the past 1 decade or so, these patients almost none of them would have survived by now. But really get a very good positive vibe and feel happy when I see these patients whom I started treating with stage 4 lung cancer in 2018 and 19. They are still doing well on that oral chemotherapy or targeted therapy tablet. They still manage to take some chemotherapy in between injections, and then they again go and visit and take some other form of tablet and then keep on responding very well. So last week I saw a patient I saw in 2018. She had extensive disease, and we thought that she would not survive more than a month. But she responded to the tablet, and she came a week back. That is about 8 years of follow up, and she doesn't have a tumor inside her body. She's still taking that tablet. So this is a huge leap from not surviving for a week and month to surviving for like 8 years without a disease with just tablet a day. So as a clinician, it gives me immense proud and hope that things are much improving, and it will continue to improve in the days ahead because we are seeing the benefit of these new drugs and new treatment strategies, which is very rapidly evolving in lung cancer. So I am very hopeful and optimistic about it.
Okay. And before concluding, sir, I always ask one strong message to, as there is awareness on May 31st, no tobacco day. One strong message from your side, sir.
Yeah. So I would still say at least about 60% of the lung cancers in India are directly or indirectly related to smoking. So someone in your family who is a smoker, please advise him to quit this habit. And there are psychological ways, clinical ways, and pharmacological drug ways which we can help these patients to get rid of smoking. In case if I tell you, if the patient or someone who has smoked for 15 years and he somehow stops smoking for the next 15 years, then majority of the uh, tumorogenic effect of these erstwhile smoking reasonably get reversed. So if you can somehow convince someone to leave smoking and let him not take another cigarette for the next 15 years, then probably his body would have get rid of all these toxins and carcinogenics in his system, and his chances of getting lung cancer would have significantly decreased. Despite said and done, I would request someone who's having some in their house, in their neighbor, who's a chronic chain smoker, and he can afford a minimal low dose CT scan cost, please see a local chest physician and oncologist and get that thing done in a local radiological center. It will help us in diagnosing these small peripheral tumors earlier. And you can be treated in a stage one, and hopefully you can have a remaining healthy, normal lifespan compared to any other normal person in this earth. And even if you rarely get diagnosed with this advanced lung cancer, you go and see your local oncologist. He will subject you to a battery of tests. He will pick out the best treatment option for you, and in half to two-thirds of the cases, it will be non-chemotherapy based treatment, and you'll recover and do very well. And hopefully, will have a reasonably good quality and long life as well with this treatment. So that's my recommendation for each and every one of you.
Thank you, sir. Thank you, doctor, for enlightening us and taking us through the vital aspects and explaining each and everything related to lung cancer. And sir, also uh, thanking this backend team support, Voice of Healthcare team for supporting us to initiate this platform to create fight against the lung cancer. Platform name is Respire. Thank you very much. Thank you all. Thank you, sir. Thanks for your valuable time once again. Thank you.
Thank you. Thank you.
Over to you, Sandesh.